think it's time. I think it's time to get going. Um, well, first of all, I want to thank everyone who's joined us again. It's really a pleasure to see so many folks on the line. I know it's a challenging time for everyone, and it's always tough to get on Zoom later at night, especially if you do it a lot during the day. So we appreciate you being here with us. My name is Rich Joseph. For those who don't know me, I have the privilege of serving as the medical director at the Center for Community Wellness at Sportsman's Tennis Center in Dorchester. And I was just telling some of the folks on the line just a bit of the evolution of these talks, which I'm calling community convos, sort of discussions around issues in medicine and health and race and community. And we did a good amount of outreach around COVID and talking about health disparities around COVID, and then did another forum around the COVID vaccine trial, and got some good feedback from that, and thought that folks enjoyed it, and was a good way for us to take some of what's happening, some of what was happening internally within the healthcare system, and just some of these larger discussions around topics that intersect with race and health and everything that's going on in the news right now, and actually have a conversation, with folks from the community, and get questions and bring experts to help address topics that are top of mind for people, and also confusing and challenging in some respects. And so this is my attempt to sort of continue that discussion series, and my plan is to keep doing them as situations evolve and as topics come up in the news. And obviously, recently colon cancer has been a topic that's been trending in the news, with the untimely death of Chadwick Boseman. And so had a lot of people reach out and think about, we should talk more about this. Obviously, it's an issue that affects people in disparate ways, and there's health disparities that play into this discussion as well. And I can't think of anyone better to bring to this discussion than Dr. Nicolette Rodriguez and Dr. Nadine McCleary, and who are both experts on colon cancer. And Dr. McCleary works at Dana-Farber Cancer Center, and Dr. Rodriguez is at the Brigham with me. And so had the privilege to be connected with both of them. And I think this is what we're trying to do, is give them a bit of a platform to access folks like you in the community and have this discussion. And so I'm excited to do that tonight. And so what I'll do is I'm going to lead these discussions, because I think it's hard to have people jump in, randomly. But I would love for this to be an interactive discussion, in the sense that people can chat me questions. I have a bit of an agenda for the sort of flow of the discussion tonight. And so you can feel free to chat me questions, and I'll take note of them. If I can't ask them at that exact time, I'll try to get to them later too. And so please engage. It's not just me asking questions. Like, I honestly want these questions to come more from you than from me. But hopefully we will hit a lot of the topics that are pertinent on people's minds. So I thought where we could start is maybe with Dr. Rodriguez, just talking about, first of all, the colon in general, and what is the colon? We think about this word, the colon, and sort of has some stigma around it. People don't want to talk about it. Why is it important, I guess, just from like a health perspective, that we pay attention to the colon?
Yes, that's a really good question. So thank you again for inviting me to this discussion. I think it's a very critical discussion and does come at a very good time. So the colon is an organ like other organs in your body. So you have your heart, your kidneys, and your colon is part of your GI tract. So your GI tract actually extends everywhere from your esophagus down to your stomach, and then goes into your small intestine, and then your large intestine. So when we are talking about the colon here today, we're specifically talking about your large intestine. And the large intestine is actually made up of two areas that we're going to touch on today. So a lot of the things we're going to be talking about are colorectal cancer. And so you have the colon and the rectum, and they're all part of the same tube. But it's important to know that the rectum is approximately the last 12 centimeters of the colon. And the reason this is important is because if we find a cancer in the rectum versus the colon, for example, the treatment and the surgeries that are available are different for each of those two types of cancer pathologies. The colon is really critical in just a balance in your body of making sure the small intestine kind of absorbs the necessary nutrients and an exchange of different fluids that we need. And then in the colon, we kind of extract the nutrients that we don't need. So we've already absorbed everything that we need to kind of keep us going in the day and our energy. And then through our fecal matter, which we pass through our colon and our rectum, that is what the colon is really there for.
So it's somewhat of a receptacle tank in some ways, but obviously keeping sort of transit through the colon is really important. And people know, we'll talk more about the downsides of not having enough transit through the colon, constipation, things like that, which I know are also common issues for people. And so when we talk about cancer and colon cancer specifically, maybe we could talk to Dr. McCleary now too, and either of you, can jump into at different times. If you have more to add, please just let me know. But how does colon cancer start? How does it start? Where does it usually start? Yeah, we'll go there.
So I'll jump in. I'm a GI oncologist. So when Dr. Rodriguez is referring to the gastrointestinal tract, those are the diseases that I focus on when they become a cancer. And one of the highlights for me as an oncologist is that oftentimes we're not able to screen or detect cancers early. And colon and rectal cancer is one of those exceptions that we're able to screen and hopefully detect these cancers before they become a problem, before they spread. So we use colonoscopies to be able to look at changes within the GI tract, within the colon and the rectum specifically, to identify early changes that may be quite subtle, but may show up as a polyp, an early or precancerous lesion or growth that can occupy a space within the colon or rectum. Oftentimes, when the screening is done early and appropriately, those precancerous lesions can be removed, and we can reduce the risk of that spreading and becoming more problematic. So for me, the best news that I can hear when I meet with someone is that you actually don't need me, that there's no subsequent treatment that needs to happen because a colonoscopy was done early enough where that cancer could have been removed and you don't need to meet with an oncologist. How these cancers develop has been worked out for a number of years now, and there's the number of changes that happen within the cells that lead to a colon cancer. But the ways that we get there are still debated and somewhat different depending on the populations that we're looking at.
And that's, yeah, I'm sorry, just Ted had a question too in the chat about just cancer in general, sort of how it starts. And right, it's not, we talk about colon cancer, people also know there are lots of other types of cancer that starts into other different parts of the body, and usually by somewhat similar general mechanisms in the sense that the cells of the body are replicating uncontrollably, right? And so for a variety of reasons, whether it's genetic reasons or environmental reasons, something causes them to mutate and sort of just grow uncontrollably, and that can be obviously over time very damaging to other parts of the body, and that's what makes cancer so scary. And so I want to let Nicola get in there for a second. I know you have something to add here.
Oh yeah, I just wanted to add, when we are doing a colonoscopy, I just kind of wanted to walk through the process in case anybody hasn't had a colonoscopy, so we just have a better idea. So what
can we get there? I promise we'll get there. I promise.
Yeah, of course.
Yeah, we're gonna bring people into colonoscopy world for sure, because I know that's not the most fun thing for people to think about, but we're gonna go there. I promise to get there. And so just a clarifying question that I had about the colon and the rectum. Is the rectum part of the colon, or is the rectum sort of a separate entity in and of itself? And is there an important difference there?
As Dr. Rodriguez was mentioning a bit earlier, the difference comes when we think about how we treat a cancer of these two areas, colon and rectum, the types of surgery and treatments that may be offered to take care of and potentially cure a cancer. but in essence, they are continuous parts of the body. For a cancer specialist, we really don't think of them as different in terms of, how our body functions, although there are differences in terms of our approach.
So when we say, okay, so, we're worried about colon cancer developing, and, I wanted to just sort of go back to the point that you made around this idea of a pre-cancer, right? Because I think that that's a term that gets thrown around, and like, lesion and things like that. And those are sort of like
Right.
medical jargon. And so I'm here to sort of deconstruct the medical jargon. so like, what is pre-cancer versus cancer? And like, how do people know, I guess, why do we care about calling something pre-cancer versus cancer?
That's a really good question. So when we are looking at the colon, there are, as Dr. McCleary was saying, sometimes we can see polyps. And the reason we want to differentiate as to whether they are precancerous, not cancerous
And what's
at
a
all.
polyp?
So that's a great question. So a polyp is basically a growth on the lining of your colon. And so oftentimes it can just be seen as a little flat lesion, or basically an area where the lining of the colon seems to be a different color or a different texture than the surrounding lining of the colon. Sometimes it can also be raised, and other times it can be raised to a point where it actually looks a little bit like a mushroom in your colon, like a tiny little mushroom that we can see. And so if we see any of those areas, what we do is we take a biopsy, meaning we just take a piece and we send it to take a better look under the microscope to see what it is. The reason it's important to delineate whether or not this is something that is not cancerous, precancerous, or cancer is because it's going to give us an idea of what the next steps will be. So specifically, in how many years do we need to do a colonoscopy again? That will differ based on the different types of polyps that we see, or whether or not we need to send you to our colleagues, as like Dr. McCleary, to an oncologist to see what the next steps would be if this is cancer, what the treatment options and what the surgical options are. Typically, for a polyp that is precancerous to develop to cancer, it does take many years, usually between 7 and 10, although sometimes even earlier.
So it sounds like, my understanding is that a polyp is a growth of cells, sort of like you may get like, a wart on your skin, or you may get something, that may not cause damage in the future, but can become, if the cells start dividing uncontrollably, can become cancerous over time. And so precancer is like a growth, and that is different from cancer, that meaning it's growing uncontrollably, right? And so that's why we care. And so when I want to get back to some of just like the risk factors around colon cancer, right? Because I think that even just like these precancerous growths, like, are there risk factors that make people more likely to have this type of growth or develop colon cancer over time? And then also, just like, what's the balance between genetics versus lifestyle, right? Or like genetics, like what you can control, which is sort of like how you live your life, and then what you can't control, which is your genetics, so the lottery you're dealt. Right. And so if we could delve into that, that'd be awesome. I'll let both of you sort of go at that one.
We think of the risk of developing cancers in colon or cancers of the rectum as being a mixture of those things that you can control and some things that are beyond your control, things that could be inherited from your parents or within your family or your genetic line. It turns out that the component that you can't control, the genetic risk, is actually not that high. The estimates are around 5% for kind of a single gene change that would lead to a higher risk of cancer. We're learning a bit more about mixtures of different changes that come along in our family lines that could account for about a third of these cancers taken together. But that's still the minority of risk for developing these cancers. The majority of what we're concerned about, or what Rich described as lifestyle, or we also add environmental factors. These are I also think of these as some of the components you can control, which is our weights. We can control our diets, the fiber in our foods, and reducing the amount of fat content in our foods. But there are also some environmental factors that are still being discovered in terms of the diets that we have access to that we may not necessarily choose, and how that influences the lining of our gut and how we process foods. And then other environmental factors that have been discussed more recently include our exposure and our uptake of vitamin D, which has been associated for those who have sufficient amounts of vitamin D to a lower risk of colon and rectal cancer. And there have been some interesting studies that have been done looking at how we can better increase our intake of vitamin D to reduce risk of developing colorectal cancer, or for those who've already had colorectal cancer, for reducing the risk of that cancer returning.
I think another risk factor that we should also talk about and is worth mentioning is smoking. So smoking is associated with an increase in lung cancer, most commonly known in the general population, but it also poses a risk for other cancers, including colorectal cancer. So that's also something important to keep in mind.
Absolutely.
Yeah, so I think that, so my sense from hearing both of you is that there are certainly genetic causes for colon cancer, and some of which, I learned when I was in med school, and people have family histories of colon cancer, and then it's a higher risk, and so they need to get screened earlier, right? And so, but it sounds like from what both of you were saying that there are quite a few uh, things that we have more control of, not maybe total control of, but sort of how we live our lives, what we eat, how much we exercise, what our weight is, and things like that, and then our environment that has a real big role to play in terms of our risk of cancer, and colon cancer in particular.
Absolutely.
Perfect. And so I think, Ted also raised a good question here about family history, because I do think it's an important consideration, particularly around colon cancer. And is that something that people, how much should they know about their family history? Should that raise red flags if people in their family have been diagnosed with colon cancer? How do you guys think about that, or how do you talk to patients about that?
So I think knowing your family history of medical conditions is extremely important, especially when it comes to colon and rectal cancer. It's one of the reasons that I'm a GI oncologist, is because there's a risk of GI cancers in my family. And so for patients who have family members who've had colon cancer, rectal cancer, or other related cancers to those two, we definitely recommend that first we screen for other potential risk. So we're looking for genetic risk there. For many families, we don't find a genetic risk just because it's the least frequent reason that we develop these cancers. But we do find similarities in terms of exposures and diet and lifestyle. So again, those environmental factors do kind of follow along in a family and may also potentially increase that risk. And then when it comes to screening, if you do have a family member who's been diagnosed, the recommendations advise that your colonoscopy should perhaps happen earlier than the current age, which has been decreased from age 50 to now 45. And so oftentimes that screening happens about 10 years earlier than your youngest family member, or whichever age is youngest compared to the guidelines.
And that's why it's important to also tell your primary care provider, because you might not have direct contact with a GI doctor or an oncologist if you don't have any medical history that would lead you to those physicians. But your primary care doctor is really your gatekeeper. So letting your primary care doctor know what your family history is will help them delineate whether or not you need a referral to go get early colorectal cancer screening or not, or whether or not they think that maybe you would benefit from genetic testing and to be seen in a genetic counseling session first.
So that's great, and so I think family history is also is key, and sometimes we don't. Sometimes your providers may not have the time or be rushed to not ask you as in depth as they should, and so I think I do think it's incumbent on every sort of patient to really know their family history and tell their providers that for sure. And so we started touching on screening. So let's go there, because it's complicated, right? It's confusing, and there are multiple options out there now for patients, and which I think is good in a lot of ways, but there are sort of risks and benefits to all of them. And so I was wondering if yeah, either one of you would love to just give a broad overview of sort of, first of all, why do we screen, right? Because I think one of the issues with colon cancer is that sometimes it's like, we don't know if we have it, and we can talk about warning signs and symptoms going forward, but it's not something that is like, not everyone knows that they have it if they have it, right? And so that's why screening is important. And so why do we screen, and why is early detection so important, I guess, would be the questions.
Yeah, so I can start off with that. So I think the really big reason why we screen, and I think Dr. McCleary touched on this a little bit earlier, is we really have a way to prevent something from progressing into a cancer and kind of catch it before it gets to that point. So by allowing us to screen you early, we can really kind of make sure that that doesn't happen. And if it does, we're getting you connected with the right people at the appropriate time. So making sure that we take it out and we touch base with our oncology team to see what the next steps are moving forward. There are different ways to do colorectal cancer screening, and I think it's a good idea to always talk with your provider about which one you prefer and why. But I can start off by listing a few, and Dr. McCleary, feel free to add on. So the one that is typically deemed the gold standard is a colonoscopy. And the reason is because we can see the lining of your colon. If we see anything, we can also take it out in live time right then and there and get pathology results to kind of get to the next steps. So for a colonoscopy, you basically have to take a amount of a colon prep that you usually take about for 1 day prior to the procedure. Some patients will need 2, but it's typically for 1 day, and it kind of makes you just clean out your whole colon of any fecal matter. And it is a long process. You can only drink clear liquids the day before, and you will be going to the bathroom a lot. But the reason this is really important is because we really don't want any fecal matter in the colon, because if there's anything that's blocking our view of the lining of your colon, we're not going to get a good look. And then we're going to not be able to really assess for those small little polyps that could be covered with fecal matter. And we would have to have you come in again to do the procedure to make sure we're getting the best look possible. So with a colonoscopy, once we take the biopsies, based on the biopsies, that kind of delineates when we're going to do the next one. However, a colonoscopy may not be something that you want or is accessible in some certain communities. So there are other ways to do colon cancer screening. And so the most widely available way is actually called a fecal occult blood test. And it's also known as an FOBT. Basically, it's a card that you get, and you'll be asked to go to the bathroom a certain amount of times and put a little bit of the fecal matter sample on the card. What the card really tests for is for microscopic levels of blood that you wouldn't be able to necessarily see with your naked eye. The important thing, though, to know about a test like a fecal occult blood test is that you have it once a year. You can get it at your primary care doctor's office. But if it is positive, that is an indication that you would then need to have a colonoscopy. So that's really important to know. There are also another test called the fecal immunochemical testing test. It's called a FIT test for short. It's kind of similar to a fecal occult blood test, but it's a little bit better of a test. With this, again, it's a little card and you put a stool sample on it, but it's not necessarily available at every single office. And so that's why I just want to make you aware that it exists, but not that it's necessarily available. Another test that there is called, it's a newer test, and it's called a FIT fecal DNA test. And what it does is, for example, on your skin, we slough off skin cells every day that we don't see. When we go to the bathroom, we also kind of slough off some cells of the inner lining of our colon. And so what this specific test does is, like the FOBT test and the FIT test that we talked about before, it looks for microscopic levels of blood, but also looks for genetic mutations that you can see in these cells that are coming out of your colon. The really important thing to know about this test is you have to do it every 3 years, but it is not covered by all insurances. So it's really important to talk to your doctor, because you can still have the option of doing the other 2 stool card tests that would be on a yearly basis. Whichever option you choose, I think as long as you do an option, that's really the important thing to kind of get you through the door. There are also other options that we can talk about, but I didn't know if you wanted to also go into those, Dr. Joseph.
Those are great. I mean, that's a lot of stuff. I mean, I think that even for me as a provider, get confused so about what the options are now. I mean, it used to just be colonoscopy and that was it, right? And so now we have more options. So maybe Dr. McCleary, what you can do is maybe just recap that and like think, maybe just any points you have about the pros and cons to different modalities that we just discussed. And then I'd love for you to just continue that and just sort of from your perspective as an oncologist, why it's so important to have this early detection because of what what you see in your day to day.
So I'll answer the second question first. It's
Yeah.
important to have the screening so you don't have to see me,
See you.
and hang out with me. And I love taking care of patients, but one of the challenges that I've seen is missed opportunities, where screening has been done. And, as Dr. Rodriguez mentioned, it takes some work on the patient's part to do the prep, but they did it, and they didn't get the result. Or they did it, but they didn't get the follow-up that they needed to do it again. And so I think that the most important point is to get screened and get age-appropriate screening, which means now starting at age 45 and every 5 to 10 years, depending on what the finding is. But it's the finding that tells us when the next appropriate time is to screen. And that has to be combined with some other things. So another point that I'd like to echo from Dr. Rodriguez is to make sure you have a conversation with your primary care provider and have an ongoing conversation. If having access to a primary care provider is a challenge, there are many community services that will allow and facilitate free screening using FOBT or other modalities to assist in folks having access to screening. And we know that screening has made the biggest impact in terms of reducing the incidence or the initial new diagnoses of colon and rectal cancer. And so it's not that screening is just important for earlier detection or to avoid seeing someone like me, but it also has made the biggest difference since the 80s till now in terms of reducing the likelihood that we'll find newer and newer cases. So we're actually helping, even if we do detect a cancer, to find it earlier in its course where we can actually get rid of it and cure it. So I think those are the big things. I will say, as an oncologist, I am biased ultimately by the time I meet with someone, they've had a colonoscopy, and that is the most prevalent method that we use to be able to find a colon cancer. But the other modalities that Dr. Rodriguez has highlighted absolutely have a role. They are very accessible for most folks, and I think get around this hesitation that many people have about doing the prep. But it's not that bad. So I would definitely encourage, if you haven't done it, please do so.
Yeah, so it sounds like, just to recap, there are quite a few different modalities out there now in terms of how we screen people, and I think that that's great in many ways because it allows sort of some choice out there, and as directed obviously by your primary care doctor in conversation with your primary care doctor. But I think that the advantage still of colonoscopy is that if you see something during a colonoscopy, you can actually do something about it and intervene. And I think one of the challenges with colon cancer in particular is that we don't see the inside of our colon day to day, right? And this is slow. It's often this grows slowly over time, and we just may not know it. And so one of the risks is that, and I'm sure Dr. McCleary sees this often, is that people just get, if they haven't been screened, they get diagnosed at a later stage of their cancer, and then it's a lot harder to treat. And that's what makes colon cancer really difficult, I think, in a lot of ways. Right.
Yeah.
Okay. And so I think it's important still to talk about just some early warning signs or concerns that people might have about if they if they worry that they might have colon cancer, or they've heard about it, and so what are the warning signs or symptoms that people should look out for? Yeah.
So I think one of the early warning signs is we describe a change in your bowel habits. Folks tend to know how often they will go to the bathroom and have a bowel movement. And if you're noticing that you are going less often, and in some cases, maybe going more often, actually, because only the liquid part is able to get past a solid mass of stool, then that's something you should discuss with your primary care provider. But more often than that, we will have folks notice that their blood count is going down. So they have their usual check-in with their primary care provider. They've had a lab test, and their primary care provider notices that they're losing small amounts of blood, just seeing that they're anemic or their hemoglobin or hematocrit has been lowered. And if it's lower, usually that's one indication, even if you're not yet at the age of screening, for your primary care provider to start thinking about screening. Certainly, if you see what we call gross blood, it's obvious bleeding. It's not the microscopic amounts on a test, as Dr. Rodriguez explained earlier, but really you see it on a toilet tissue or in the toilet bowl. Oftentimes, folks will say, well, I think I have hemorrhoids. It's easily explained away, but bleeding is never normal. And so if you're seeing bleeding, it needs to be discussed with your primary care provider. And the best course of action is to make sure that there's a clear explanation, which generally means that someone's done an exam, and usually a colonoscopy is the only way to be sure that there's not a cancer that's present. There are other things that people can experience, but they're not as common when I'm meeting with folks. So changes in your weight, so weight loss can be seen. Sometimes pain can happen, but bleeding and changes in bowel habits are probably the most common symptoms.
That's perfect. Okay, so that's really helpful, and I think that it's important, I think, for everyone to know warning signs around colon cancer, but also other diseases that we talk about that are prevalent in society, and a lot of what we try to do here is just to give people a bit of a playbook and knowledge around these things, so to empower people as much as possible. And so let's shift a little bit now that we've talked about both screening, warning signs, and colon cancer and what it is, and talk about the prevalence of colon cancer now. And when I say prevalence, like, how common is this in society these days? And is it common? Is it more common in certain groups than other groups? If so, why? And just would love your thoughts on that. Both of you, honestly.
Yeah, so that's a really good question. So when I was looking at the most recent statistics for this upcoming year, basically in the year 2020, colorectal cancer is going to be the fourth most common newly diagnosed cancer in the US. And then in this year as well, it's also the second leading cause of cancer death in the United States. So number one is lung cancer, and number two is colorectal cancer. Again, either in your colon or your rectum. Currently in the United States, there's about 1.3 million people living with colon cancer, but it's estimated that this year approximately 53,000 people will be passing away from colon cancer, with an approximate 150,000 people that will be newly diagnosed.
Significant, right? Sounds like it's significant. Dr. McClure, do you have anything to add on to that?
Those numbers are so large and
it's huge.
somewhat overwhelming and sometimes hard to wrap our minds around. But if you think about your entire lifetime and the number of people that you meet over the course of your life, if you know 25 people, that means that one of those people will be diagnosed over the course of a lifetime. So 1 in 25 for men, 1 in 23 for women. That's very significant. And undoubtedly, certainly even before Chadwick Boseman's untimely passing, we've all had some connection to someone who has either been diagnosed and or passed from this diagnosis. So I think it just makes it all the more real. And then you also asked, Rich, about, how does this impact different populations? And, part of this forum is to really think about the disproportionate impact on Black people, Indigenous peoples of color, who are more likely to die from this cancer. The rates of new diagnoses are about the same, and that's really because of this push for screening and some insurance coverage of screening. But despite those advances and improvements, we're still seeing that Black patients, Indigenous people of color are dying more often from colon and rectal cancer. Oftentimes, when a diagnosis is made, it's made when the cancer is further along in its course and more advanced and less likely to be removed by surgery or cured.
Why do you think that is? What are your just like speculations on that? Because I think
tons of speculations, but
yeah.
there's actually a lot of interesting research that has been done to try to understand why that is. There are certainly differences in access to care. There are differences in socioeconomic status. And yes, that explains a portion of the reason why we're seeing differences in mortality from colon and rectal cancer. But it certainly doesn't account for all of the difference. And even when you look within a high income bracket of African Americans, for example, you're still going to see disproportionately higher rates of death compared to the same high income bracket of white patients. And so there have been other studies looking at, are there environmental factors, lifestyle factors, is it the lining of the gut and differences in those things that may drive it. And I think very interestingly, differences in the changes that happen within the tumor over time that may drive those differences. The challenge is that many of these studies are limited because we don't have a lot of information on what happens after diagnosis for African Americans or for other populations to make solid conclusions. But I think we're going to learn more over time.
And just to follow up on your last point there, I think one of the reasons that we do these forums too is because we think it's so important for people to get active in not just their own health, but thinking about how they get active in research that happens around these issues, right? And so, I think everyone, it's sort of like voting in my mind. It's like everyone has the opportunity to participate, right? And that sort of expands our knowledge just as a society and as a medical community about how these different conditions impact different people differently, right? And so much of our research and trials are biased by the types of people that we're able to recruit into these trials. So that's another thing that I always like to plug at the forums that we do. It's just important. People can get active in helping themselves, but also helping their broader community by doing that. And then I want to follow up on that discussion, because I think in addition to talking about communities of color, there's been, at least I've read a little bit about how colon cancer rates might be increasing in younger populations, and was hoping that both of you could comment on that as to, is that true? If so, why might that be? And any of your thoughts on that would be great.
Yeah, so that's a great question. So the rate of colon cancer among individuals around 15 to 35, known as young adults and adolescents, is increasing in the United States. It's only increasing by a little bit, but it is increasing. And so some of the thoughts that are coming into play as to why this is actually increasing include points that Dr. McCleary had talked about previously. So things like people now are a little more sedentary than we were previously, meaning we're sitting around most of the day, or we're lying down, or we're reclining, and we're not engaging in as much physical activity. And so that is one of the things people have been investigating as a potential cause of this. Another one is our diet. So our diet is much higher fat, much higher in processed meats like deli meats and sandwich meats and hot dogs, for example, things like that, which can also increase the likelihood to develop colorectal cancer. So those are two of the reasons that I know of. Interestingly, in this population, usually in individuals who are diagnosed later when we're doing colorectal cancer screening at 45 and older, Black populations are disproportionately affected. In young individuals, 15 to 30s, it's actually disproportionately affecting the Latinx population more than other groups. So that we are still, being affecting two minority groups, but the two groups are actually different in the different age brackets.
Any thoughts as to why that is? I actually just got a question from someone who I think is of Latinx background and heritage, and was wondering about how, we talked a bit about the African American population, but how does this factor in with the Latinx community too? I know Dr. Rodriguez, you think about that a lot.
Yeah, so I think that's a really good question. I think it all kind of boils down to the things that we're trying to still figure out. It's not entirely clear.
Yeah.
There are, is it because we're sitting around more? Is it because our diets are changing? A lot of the barriers to care that affect us in general show that in the younger populations, decreased access to care is also one of the barriers to individuals being diagnosed with cancers that are more difficult to treat. But right now, the data as to why it's affecting the Latinx population more really isn't out there.
Dr. McCleary, anything to add on top of that?
This is a really important challenge, and just getting back to trying to understand why this is happening. The way we understand is by learning from those who are affected, and a lot of the research that's being conducted now and supported by the NIH and other groups is really targeted on trying to figure this out. So there's a lot of support to try to sort this out as quickly as possible, and there are a number of research groups at the Dana-Farber, Brigham, and elsewhere who are tackling this challenge.
And I think this also goes back to what you were saying, Dr. Joseph, as to why we really need more people who are self-identified Black individuals or Latinx individuals to join in research studies, because less than 2% of our research studies involving genetic mutations, for example, in GI cancers are specifically targeted to our communities. And so it's really difficult for us to do research on these groups when we ourselves aren't engaging in it. And then there's a lot of history behind that. It's not easy. There's been a lot of unethical experimentation, including Tuskegee and the immortal cells of Henrietta Lacks. And so those are things that are absolutely, I understand, a fear and a mistrust in the medical community. But, we are always here to answer questions. You can always touch base with us. If you have any more questions now, we can certainly answer them too.
Yeah, no, it's great that you mentioned that, because I think that was something that, we had a forum around the COVID-19 vaccine trial, which is happening at the Brigham. And those were a lot of the discussions that we were addressing is sort of the history and very understandable and justifiable skepticism around research and getting involved in research, but also, really also just letting people know that we can't advance sort of the research and what we know, our knowledge base, further if we don't have, a collective representation of people participating in the research that we do. And I think, when people ask questions about how does this affect my sort of specific demographic or, ethnicity of people, one of the ways that we can help sort of better pinpoint that going forward is if those groups make sure that they're participating in the research that we do. Okay, I think that in sort of the latter stage of our talk tonight, what I really want to do is, sometimes we spend some of the time painting this like sort of gloomy picture for people around some of these conditions, and I want to make sure we end on a positive, empowering note for everyone as much as possible. And so talk more about colon cancer prevention. And when I say prevention, we've obviously talked about screening, which is a huge piece of prevention, sort of in the traditional sense of what we mean by prevention. But what can individuals do, even separate from sort of seeing their doctor and even their primary care doctor, in their own lives to make a difference in terms of their risk for colon cancer, right? So I think about how do we create sort of like the soil or the environment in the body that is sort of anti-cancer, right? And so I was just wondering, I think we'll have a multiple rounds of discussion around this topic, but I'll open up to Dr. Rodriguez, if you want to go first and just sort of share some of your overview on how people think about that. And I have specific questions to go forward to.
Yeah, so I think we touched on it at different parts of the talk. I know Dr. McCleary and I mentioned it. Physical activity is really, really important, because being overweight or being obese not only increases your risk for colon cancer, but also increases your risk for a plethora of other different diseases, including heart disease and other cancers. So being able to lose weight and also engage in physical activity is really important. And when I say, physical activity, even just doing like 15 to 20 minutes a day, 4 days a week can really, really help. Other things, to kind of make our bodies the best way they can be to be protective against cancer is really to not engage in smoking. And the reason is because smoking, increases your risk for lung cancer, but it's also a lot of research has been shown that it increases your risk for other cancers, including colon cancer and pancreas cancer. So that's another thing that we can kind of take control of for ourselves. And then the other thing is just talking with your friends and family about this. Colon cancer and colonoscopies, there's a stigma about getting colonoscopies, but really the more you talk to people, the more it's easier to kind of share your experience about how the procedures went, how quickly they went. They really don't take that long either. They take us like 30 minutes. And then you can be set up to 10 years before the next time you need to be on. Those are kind of the big things that we can do.
Dr. McCleary, what, from your perspective, would love to hear your thoughts on.
I love the emphasis that Dr.
prevention.
Rodriguez places on working within your sphere of influence and not just focusing on your own well-being. We are heavily influenced. We talked about our environment, but we're heavily influenced by those who are around us. And so I think using that influence to better our collective health is incredibly important. So, first and foremost, we've had a lot of discussions today, and hopefully there'll be questions soon to follow, but taking some of what we've spoken about today to your family, to your friends, to your social networks, and making sure that folks are aware. Reflecting on the passing of Chadwick Boseman, I think did highlight some awareness, and my hope is that in addition to his other extremely important pieces of legacy, that part of that legacy is the fact that we are all susceptible in some ways to this. I like to comment on the fact that while we can't prevent disease necessarily, I think we can do a whole lot to stack the odds in our favor. So activity for sure, secondary prevention or primary prevention, so making sure your vitamin D levels are adequately repleted, speaking with your primary care provider, being aware of your family history. Trying to understand what diseases, if any, have impacted your family, so that you can see if you fall in the normal risk category for screening at age 45, or if you should start a bit younger. But really try to do all of those things that you can do to stack the odds in your favor, which includes having and participating in conversations like this, so we can learn more about how this impacts our community specifically.
I've gotten some questions here about diet in particular, and I know diet's a confusing world for many of us, and even in the research world, it's very hard to do specific studies around particular diets in general. And so, but people are wondering about what types of foods may contribute to colon cancer, or may create the sort of setting in the body that makes it more likely to happen, versus what types of foods or diets people can follow to lower their risk.
So there have been some excellent studies actually looking at the so-called Western diet, the U.S. diet, and we know that diets that are high in fat, heavily focus on protein, particularly red meat, do lead to an increased risk of developing colon rectal cancer. Diets that are high in fiber, those diets that are more cleansing, tend to be lower in risk. There was an interesting study that I found where in the same population, so in Black patients or individuals living in South Africa compared to Pittsburgh, diets were switched just to see if it made a difference in terms of just how healthy the gut was. And by increasing the fiber intake in the population living in Pittsburgh, they were able to see that the gut lining was much healthier and had improved and had more favorable constitution than it previously did. And that transformation happened pretty quickly within 2 weeks. So, when we talk about diet, there's some small changes that can be made, but the impact is significant and can happen very, very quickly.
When we say fiber, what is fiber? Just generally speaking, and where do people find it, and what types of foods are you most likely to find fiber? Because I think that's another thing about nutrition, is that we throw some of these terms out there and sort of just, we unfortunately don't get much nutrition training in
No.
lives, nor do we in med school, quite honestly,
No.
right? Like, be honest. And so, like, where do people find fiber? Where, like, sources of fiber that people can get, or even like supplements people can use to help increase their fiber intake? What do you recommend?
Veggies, lots and lots of veggies. It's the roughage, just the nutrient that helps us to really pull in and get rid of the fecal matter in the colon, in the rectum, and do so with regularity. So vegetable intake is important. You'll see it in the skin of some fruits as well. And there are supplements that could be added to the diet if you are not taking in enough of that kind of in its natural form. But that is where you can find the best sources of fiber.
And diets and fiber can also really help with constipation. So for people who are having a lot of trouble going to the bathroom and are not going regularly or straining, increasing the amount of fiber in your diet can actually help decrease that and make it more comfortable for you to go to the bathroom and have a bowel movement.
Sure, definitely. Water and fiber, I think, are big, important pieces of the puzzle here. And so, particularly around green vegetables in particular, I think sometimes we lump fruits and vegetables together all the time and saying that they're all equal. They're not all equal, right?
Yeah.
And certain ones have a much higher fiber content than others do. And so, I really try to counsel patients around green vegetables in particular, and obviously sort of whole grains are also good sources of fiber. But I think that I'm glad we talked about that, because I think nutrition is a very complicated subject, and sometimes we sort of just say, oh, eat healthy, eat fruits and vegetables, but that can mean a lot of different things to a lot of different people. And so being specific around fiber, I think, is really important for people. Okay, that was helpful. And then hold on. So what is I just had a question related to constipation now that we mentioned it, and is there any association between constipation and colon cancer, and maybe a little bit of a discussion around sort of transit time more broadly? Like, is that like just making sure things are passing regularly through the colon, does that help prevent colon cancer? What are your thoughts on that?
That's a really good question. So I think Dr. McCleary had touched on this previously. So sometimes if there is a tumor that's blocking our ability for fecal matter to pass by, then we'll only get liquid, and we might feel the sensation that we are constipated, especially if for some reason someone feels like they need to go to the bathroom a lot and have the sensation that nothing's coming out, in conjunction with other symptoms that they may be having that we discussed. The important thing about being constipated is ideally we want you to be able to have at least 3 to 4 bowel movements a week. And so Dr. Joseph had mentioned the most important thing is actually just increasing the amount of water that you're having, because that'll really help things move forward. Another thing which he had mentioned is gut transit time. So basically, how fast is our colon kind of propelling the fecal matter through? And so if it's not doing it well enough, we can get constipated. And things that can actually help with that are physical activity. And it kind of makes sense, because the more we move around, the more our gut can move around. And so the faster it is that we'll be able to kind of go to the bathroom and be a little bit more comfortable.
Perfect. Anything else to add onto that, Dr. McCleary?
Just one caution that sometimes when we discuss constipation, there's some kind of differences in how folks define it. So I'm so happy Dr. Rodriguez kind of gave us a bit of a definition on what we would expect, 3 to 4 bowel movements a week, but also making sure that you are completely clearing. And if you're still feeling that you're not cleared after a bowel movement, then you may still, in fact, not be clearing your gut well enough. And so increasing your activity, increasing the water, increasing the fiber, and paying attention. I don't know how many people turn around and actually look at their stools. I'm going to be pretty blunt, but you need to turn around and take a look and see what it actually looks like. Because if any of those things aren't as expected and fully formed, then that is a conversation that should happen pretty quickly with your primary care provider as well.
And things that you should look out for, like Dr. McCreary was saying, that we've mentioned before, but just to kind of reiterate, is if you're seeing blood, if you're seeing dark maroon colored stool, and sometimes, if you're seeing like pencil thin, really thin stools, it can mean that there's something blocking that's kind of making your stool kind of look like a pencil. And so those are the things that you want to make sure you can take a good look at, because if any of those things are happening, you should tell your primary care provider as soon as possible.
Great. So I have a few questions around, for people who are, listen to the news, they read magazines, and they hear different things about. So one topic is probiotics, right? How do probiotics help with sort of gut health and, maybe a relation to preventing colon cancer in general, and then also the role of the microbiome and like what, how are we learning about the microbiome and how is that influencing what we know about colon cancer? I'll let both of you go for that one.
So, when we think about our gut, the lining of our colon, rectum, and small intestines, there's certain normal bacteria that help us to process and extract the waste appropriately. Oftentimes, we can eliminate the good bacteria, so to speak, because of our diet or because we've had certain course of antibiotics. And so I think of the microbiome as the normal part, the part that we want to be there, the part that helps us to process our waste appropriately. And probiotics or our diet can help to replenish and normalize that gut bacteria again. Oftentimes this conversation comes up most when we are giving chemotherapy. We know that we can get rid of the normal gut bacteria, and so I actively advise patients to take probiotics in that setting. But I think the bigger question is, by taking probiotics, can it help to prevent or reduce the risk of colon cancer? And I think there's a lot of information that's still to be discovered about the best way to do that. I personally don't think it harms, but I'm not aware of any data that tells us that it will prevent the risk of developing this cancer specifically.
Dr. Rodriguez, do you have thoughts on that from your perspective?
I think a good way to think about our gut too, which you had mentioned in terms of the microbiome, is really kind of the balance of the good bacteria and the bad bacteria in our gut. And the probiotics will really help replenish the good bacteria that kind of help in digestion of our nutrients that we're taking in.
Got it. Yeah, and I think it's a fascinating topic that we're learning a lot more about the microbiome every day and its relation to all different parts of our health and sort of all these little bacteria and microbes that live within us. And I think the interesting part about the gut too is that, and most people maybe not think about this, but it's really the only part of our inside that's really exposed to the outside, right? Like it's really exposed directly to our environment. If you think about it, it's just a long tube, right? That starts in our mouth and goes all the way to the rectum. And so it's exposed to everything that we eat. And to your point around smoking, I mean, that's probably one of the big reasons is that that's a toxin from the smoke, and that gets not just into our lungs, but also into our gut and goes throughout. And so, being thoughtful about what we expose our individual environments to, I think, is really important too. Because, okay, perfect. I had a few questions just from some folks too that I wanted to get to make sure we answer their questions. And a question about hemorrhoids and their relation to colon cancer, rectal cancer. Is there sort of an association here or a relationship that we should know about? I mean, I think what comes to mind for me is that obviously hemorrhoids can also cause bleeding, and sometimes that makes a risk. People, if they have hemorrhoids, can get freaked out that they have colon cancer. And so, but is there actually like a risk that if you have hemorrhoids, you are more likely to develop colon cancer?
So there's not a risk that I know of with hemorrhoids increasing your risk of colon cancer at all. Hemorrhoids are basically like varicose veins that are in our rectum almost, where they kind of just pop out when you strain. They kind of increase and get bigger, and then they can pop, and then that pop and is what is causing your bleeding. And so it's important to tell your doctor, because we need to make sure it's not anything else. But when we look at your colon and we don't see anything else, but we see the hemorrhoids, we say, okay, the bleeding was probably from that. You're going to see some bleeding sometimes, but the important thing is to keep your stool soft. So, drinking water, increasing your fiber, making sure you're not constipated. But it's not associated with colon cancer. The important thing about hemorrhoids too is there's actually two types. You can have internal hemorrhoids and external hemorrhoids. And when you bleed from your internal hemorrhoids, you're not going to feel any pain. But when you bleed from your external hemorrhoids, you can feel pain when you're bleeding. So that's just another good point when you're telling your doctor. Just make sure that you're letting them know whether it's bleeding or it's not bleeding. I mean, painful or not painful.
Yeah, no, that's great. That's really good. Perfect. And then I had a question about, I think some folks who are dealing with constipation may take supplements for that, some Miralax or other things that help sort of keep you regular. Is there any side effect to taking these things long term? Any risks that with connection to colon cancer at all that you guys know of?
No risk associated with colon cancer or rectal cancer per se, but I do think if you see the need to take supplements long term to be able to maintain regular bowel movements, then that probably is a conversation that needs to happen as to why that is. Is there something else that we should be concerned about? And if you've not had an evaluation, it's probably worthwhile having an evaluation to make sure there's nothing else to worry about.
And it's important to touch base with your doctor to let them know which supplements specifically, because some supplements that you can buy over the counter are actually only meant to use in the short term. But when we use them in the long term, we can actually have too many bowel movements, and then we're kind of losing certain electrolytes like potassium or sodium in our body to an extent that we shouldn't. And it would be important for us to know how much you're taking and how many bowel movements a day you're having on that.
Are there any supplements and sort of from like an anti-cancer perspective that either of you know about or recommend to patients?
So there are actually two that have been associated, and there are a couple that have been kind of debunked. So vitamin E and selenium both have been not been shown to be beneficial in terms of reducing risk, and in some studies potentially harmful if taken in excess. But vitamin D has been shown to be beneficial, and most primary care providers will discuss the importance of vitamin D supplementation in terms of reducing risk for colon and other cancers and improving overall health. And the second is aspirin. We think of cancer as an inflammatory state. Aspirin reduces inflammation. And so, especially for patients who have had a diagnosis of colon cancer, we recommend a low dose of or baby aspirin to be taken daily, as long as there's no other reason that you can't take an aspirin.
That's great. And I think I wanted to just sort of touch on your point around inflammation, right? Is that term is often one that we hear a lot about these days, and sort of getting at sort of the root cause of some of these illnesses. And so, many cancers, diabetes, and many other conditions that people are dealing with today in terms of chronic conditions, right, sort of have this common root of inflammation, or sort of, creating the body in sort of an inflamed state. And many of the things that we talked about today, whether it's dietary factors, having excess weight, things like that, create sort of this environment within the body that can predispose you to many different types of conditions, one of which is colon cancer that we've talked about today. And so I think it's also important for people to look at this as sort of within the spectrum of other illnesses and diseases as well. And sometimes in medicine, we really classify a lot of things very discreetly, which I think makes sense for a lot of reasons, but also, many of these things are related to each other in just the way that they evolve and develop within the body. And so that's why, we like to empower people as much to take as better care of themselves as possible to reduce that inflammation in their bodies. And so, I think we've touched on some of those good tips tonight. And so I, want to be respectful of people's times, of course, and would love to just hear maybe some a few take-home points from each of you that I think, people could really take with them for themselves and also for their families and friends to teach them what they learned tonight.
I'd love to end with a positive note.
Yeah.
We didn't speak about, we kind of touched on the diagnosis and the risk for mortality and some prevention. But, even if someone is diagnosed with colon or rectal cancer, there have been so many improvements and so many advances and so many learnings over the years. And so I have seen colon cancer move from one that has a short life expectancy, was actually pretty close to what we think of for cancers of the pancreas or esophagus, to a cancer that has a longer life expectancy, and have been able to see many patients, even those with advanced disease, ultimately be cured of their cancer. So even in advanced stages, there is opportunities for us to be active and proactive and help to improve quality, but also length of life and actually cure disease. Still want to emphasize, however, that, the best thing that we can do is try to stack the odds in our favor, reduce risk as much as possible, participating in screening. And if you have the opportunity to participate in a research study where we can find out about why we're seeing what we're seeing and what we can do about it, please do participate.
I think another take-home point, I echo everything Dr. McCleary is saying, and another take-home point is just to talk to your family and friends about the importance of screening, what you guys have learned here. I really feel like the people who have always had the most impact on me are my family and friends, and I think that you can be that person for somebody else, to just let them know that it is important to get screened. It's one of the only cancers we can screen and kind of catch it before it's too late, and catch it when it's early, and the odds are really in our favor to have a cure for you.
And then for people who have additional questions or want to do additional research around colon cancer, do you have any good places that you point your patients or people you talk to?
Absolutely. So at the Dana-Farber, there is a new center, the Young Onset Colorectal Cancer Center, that has a research study called Beyond CRC, or Beyond Colorectal Cancer. And for those who are diagnosed, and soon will be asking healthy family members of patients who have been diagnosed, they're looking at samples of blood, samples of tumor tissue if someone's diagnosed, and also samples of fecal matter to try to understand what some of the causes of earlier age of diagnosis could be. So absolutely would encourage folks, if they're interested or able, to participate in that program or know someone who could. There's another program that is available as well for those who are not in this area, but who are away from this area, that is run by the Broad, by a colleague, Nikhil Wagley, where folks can participate without their providers being aware of it, and submit their own tumor tissue and information about their diagnosis. And that is really patient-driven and patient-run, where patients are sharing their information to try to learn from each other about diagnoses of cancer, including colon and rectal cancer. And that study is called Count on Me. And so those are two opportunities at the Farber and the Broad specifically that are available.
I'll put those in the chat right now.
Thank you.
Yeah, of course. And Dr. Rodriguez, anything from your perspective?
I think if you just want to kind of get a little bit more nitty-gritty on the numbers of colon cancer and other cancers, and you're interested in what type of racial disparities, the CDC actually has a really good website. And if you type in CDC stat cancer facts, it'll kind of give you the most up-to-date data in 2020 for all different types of cancers, racial disparities, and age disparities that we've been mentioning. So that's a really good website that I go to get that type of information.
Thank you. I want to thank both Dr. McCleary and Dr. Rodriguez for taking time out of their busy schedules and lives to come have this conversation with us tonight, and thank all of you for doing the same. I know all of us have a lot going on these days, and it's our pleasure really to bring these conversations to you guys and help to sort of just amplify the collective health knowledge that's out there for all of us, right? Like, we learn as much as you do from having these conversations, and so it's really helpful to talk, and your questions are always wonderful, and so it's our pleasure to be here with you tonight, and just want to thank both of you in particular for coming out, and we look forward to having these conversations ongoing.
Thank you all so much. It's fantastic.
Perfect.
Thank you all for having us. And if you have any questions, you can feel free to reach out and let Dr. Joseph know. We're here if there's anything else you want to ask offline.
Absolutely.
I'll put my email in the chat for folks, and if you have any sort of questions that you'd want to ask to me specifically, or to either Dr. McCleary or Dr. Rodriguez, please do so. We want to be available resources for all of you, and keep bringing you this information. Okay, so everyone take care, get good rest, and we'll see you soon. Okay.
Have a good night.
Thank you.
Good night. Thank you. It was wonderful. Thank you.
Pleasure. Thank you all.
Bye.
Stay safe.